So I might see 30 patients in a day in my clinic, and 20 of those patients need it to monitor their disease and response to treatment. In some patient populations, it's even higher. Some of my partners, some of the ones who are tenured professors of ophthalmology and have been doing this for years, and they see 40, 45 patients in a day. Heaven forbid, 90% of their patients. For retinal disease. If you're not a retina specialist, yes, it's quite a bit less common. You'd have to suspect that someone has some retinal problem, some macular problem that you can't diagnose just by looking into the retina. So for them, they might use it, say, 10% of the time, but still not trivial.
Does this work similar to a CT scan where you can vary the linear depth at which you're getting in? Like, can you get multiple slices, or is it just of one?
Right. So the answer to the question is yes. However, we're limited by the scattering of sort of non-ionizing light. So we can really only get a depth of about maybe a millimeter, so 1,000 microns. Whereas a CT scan, you can get a CT all the way through someone's head, right? But yes, absolutely. So we're taking what we call A scans, so a reflection off of one point, then we're adding them all up to create a line, to create that sort of horizontal, let's go back to an OCT, a regular OCT. Yeah. So this we call a B scan, and then you can add up these B scans to create what a C scan, so that's sort of a volumetric rendition. But again, that's only going to give us a depth of about 1 millimeter.
And are you getting a full image of the eye with that, or is that just...
We can get about, with the common cameras and lenses that we have, the devices that we have commercially available, we can get at most about an 8 millimeter cross section. We can't get the entire, say, back of the back half.
So that's not
of
cropped. That's like a typical image.
This is not cropped. Absolutely not. Yeah. You can get a montage. You can take a couple of OCTs and put them together, but it's usually not useful. Usually, most of the pathology just meaning diseases, common diseases, is right here in the macula by the fovea. So, but to give you a reference point, the eye is typically 24 millimeters long, right? So that's the typical diameter of the eye. So the radius is 12, and then you can calculate the surface area of the back half, which is where the retina is. So this 8 millimeters is pretty good.
Yeah, it's cool stuff.
Yeah. Is there a question of
what is the light source? Is that a laser light source, or?
Yeah, so the early ones were lasers, and it was a laser interferometry, but that had various problems, and so I mean now it's, I don't actually know exactly what it is, but it's no longer a laser. If you want, I can find out for you and email you. But although we may have it actually on that initial slide, which is one I got from one of my old engineering colleagues at Penn. But the light source, not sure. But the early ones, it was a laser, no longer. Did I choose, or do you want to?
No, you go ahead. You're facing
we'll start here, and then we'll. Yeah.
So Dr. Sandhu is excellent presentation. I learned a lot about the real application of RCD. So my question here is, what are the obvious challenges? And imaging is gaining a lot of traction in other areas of medicine too.
Yes.
And as you said, it's still in the beginning phase of diagnostic applications.
Right.
What about, say, various age groups, say children, adult, and the parameters which are well suited for the chronic conditions, as one ages?
Yeah.
Then the growing kid, 8 or 10 years, does it work absolutely fine for them as well if they need to have evaluation by a retinal specialist?
For say children.
Yeah, say genetic conditions and retinopathy, something like that.
Right. So the answer is someone has to be able to look straight ahead for about 90 seconds. So usually once you get up to age, if you have a good 6 or 7 year old, they can do it. The useful, so then sort of a question that's related but is separate, which is the genetic diseases, which generally are going to present earlier in life, though not necessarily. What's the usefulness? Can we detect certain like genetic retinal degenerations? The answer is yes, because the retinal degenerations will usually give you an atrophic change in the retina. So, for instance, I showed you that that zonal retinopathy. Let me see if I can find it again. So you usually will find atrophic or dystrophic changes in the retina. So you'll see, here's a great example. So this structure here is something called an outer retinal tubulation. And we don't know exactly what it is, but from correlating it with histology, we believe it's essentially photoreceptors that have started to die, and then for whatever reason, they form this kind of circular pattern. And this is a final common pathway of photoreceptor death. So you can see either earlier changes, which are thinning of layers from death of cells with absolutely no other presentation, and then as you get to sort of medium or more advanced stages, you can then see some of the final common pathways of cell destruction. So actually, yes, it's not specific, I will tell you, so that is one of the challenges, but it's highly suggestive for a much narrower range of conditions. So you see this in an old person, it's probably from macular degeneration, a degenerative age-related disease of the retina. But if you see this in a kid, again, they have to be old enough to stay still for maybe 90 seconds. Highly suggestive of a genetic disease that's causing degeneration. Now, we actually have portable handheld OCTs. So if we need to get an OCT on a 30-day-old, I've done it. We take them to the operating room. We don't do any surgery, but we sedate them with an anesthesiologist under general anesthesia, and boom, we go right over the eye and we can do it. So it's amazing just how flexible this technology has become. In terms of then just other challenges, so the 1 millimeter, outside of ophthalmology too, obviously that's not my expertise, but the sort of 1 millimeter depth is the biggest restriction. So the other area where this is being used heavily is in cardiology, where they're trying to image coronary arteries with this technology. And coronary arteries are very small, and you can thread catheters into the coronary arteries. That's how a lot of heart attacks are treated these days. But for any other tissue where you can't get right up to the surface or very close to the surface, where we're 24 millimeters away from the retina, pretty close, with an optically clear medium, I don't know how to overcome that with this technology. That may be an indefinite limitation. I don't know. Because, of course, the scattering from the biological tissue becomes profound, and eventually it becomes all noise and almost no signal. So I might even turn that one around to you and say, how do we go beyond that? But yeah, those are the immediate difficulties that I see. Yeah.
Thank you.
You're welcome. And there was a question over here.
Yeah. Are there eye diseases that doesn't cause vision loss?
Eye diseases that don't cause vision loss. Absolutely. Most of the diseases in the retina in which I specialize cause vision loss because it's the neural tissue that detects light. So a structural abnormality usually causes some functional deficit in vision. Are there other diseases that don't really cause vision changes but cause, say, for instance, pain? Absolutely. So if I take you all the way back to this patient. This patient had trauma to the eye, okay? And they developed a partial thickness laceration here, which is healing and didn't need sutures. They had post-traumatic inflammation in the eye. But once this inflammation settles down, they will have no change in vision, but they may still have pretty significant pain from having had a partial thickness wound in the eye. You can also get inflammatory diseases of the sclera. The sclera is the white of the eye, so that's this part here. So you can get inflammation of just the white of the eye. And those patients will see perfectly, but they'll have tremendous deep pain. You can also get diseases like glaucoma, which are both painless and have no central vision loss, but you start to lose the peripheral vision. And patients only notice a problem very late in the disease, usually when it's almost too late to intervene, sadly. But yes, if it's not vision loss, if it's not central vision loss, it's either peripheral vision loss or it's pain. The final thing that can happen is that you can have visual disturbances. For instance, the central vision's fine, but people will see flashing lights off in one corner. That can be a very early sign of retinal detachment. Usually it's not, but it can be. So there are, absolutely, there's a whole host of things. But for the retina, which is my area, it's almost always vision loss.
So just a couple of quick things.
Yeah.
In terms of looking at OCT, OCTA, what is it that is on your wish list that these technologies cannot detect, that you wish there was a technology that you can detect?
Yeah.
Because as an engineer, that's basically what we want to try and figure
Yeah.
out.
Yeah. No, that's a great question. I mean, so we almost never do. So in most fields of medicine, you can do a biopsy if you don't know what something is. You do a CAT scan of the chest or the abdomen. You see some mass on the imaging technology. Someone can go in with a needle, sample the cells, show it to someone, a pathologist under the microscope, and they can tell you exactly what it is. We almost never do that in the eye because of the functional consequences. Because the patient's going to get a blind spot from taking out a big chunk of retina and some other eye tissue. Plus you can get complications from that. So, we're at a major disadvantage, and that's why we have this whole tradition of trying a physical exam and trying to figure out what something is based on physical exam. OCT was a big jump forward, but it's still not anything like a biopsy. So what I would love would be, so for instance, I'll give you a typical, what we call diagnostic dilemma. We don't know what something is when we look in, or even when we get the OCT. You can get inflammatory changes in the eye. So you can get a patch in the retina that's just like, it looks creamy and yellow and it's clearly abnormal. But we won't know if that's infectious or if that's autoimmune. And the difference is absolutely critical. If you treat someone with an immune suppressant medication, like steroids, you destroy the eye if it's an infection. Because the infection loves the fact that the immune system is suppressed, and you get massive exponential increase in the microbes. Boy, would we love that. You can also see cells floating around. So this patient has cells. These here are inflammatory cells. What we don't, if we saw this patient a week after cataract surgery, let's say it wasn't trauma, it was a week after cataract surgery, we wouldn't know if these cells are just inflammatory cells or if they're a mixture of inflammatory cells and bacteria. So if we could get a technology that could somehow image cells and tell us this is an inflammatory cell, like a lymphocyte, versus this is a bacterium, that would eliminate all of the diagnostic uncertainty from this whole class of cases. Is this infection or is this inflammation?
So how do you treat them now?
Right. So the way we treat them now is we treat 90+% of these patients as though they're infected, which means that we stick 4 needles in their eye in the office, which is very unpleasant, particularly when they're inflamed. We stick a needle in the front chamber of the eye, we sample fluid. We stick a needle in the back, we sample fluid. We send it to the lab to grow and culture. And then we stick 2 more needles in to treat that are antibiotics. They're both broad-spectrum antibiotics. So basically, almost all these patients, the default is to treat them as though infection, because if you miss infection, you destroy the eye. So we put a patient through a very painful, costly, and time-intensive procedure that in maybe a third of these patients was totally unnecessary, because they don't respond to the antibiotics, they don't grow anything on the cultures, and that's because there was no bacteria in the eye. It was what we call sterile inflammation the whole time. And then eventually we build up the guts to start them on a steroid, and they degrade. And that is what we call both a diagnostic and therapeutic maneuver. So we treated their inflammation, but we also confirmed the diagnosis, hence the term diagnostic maneuver, because they responded to a medicine that would only treat sterile inflammation and wouldn't treat infection. So these are the sorts of cases that keep us up at night, and that's why we basically just we are essentially, to employ a crass term, nuking these patients with medicines and with procedures that they may not need. So we would love that. We would love that. I would love that in particular as a doctor who specializes in inflammatory diseases of the retina. Whether, in terms of what the general ophthalmic community would want, I'm not sure. I'd have to think more about it. But this is a dilemma that comes up to me almost once a week.
And you were talking about diabetes and
Yes.
how the cells and the vessel integrity is, or the capillary integrity is lost.
Yes.
Is that unique to the retinal capillaries, or is it something that's common?
Yes.
Pretty much.
It is common in small small vessels throughout the body in diabetes. And so that is why diabetes preferentially affects the kidneys, because the top of the nephron, so the terms don't really matter, but when blood flows into the kidneys, it flows first through this ball called the glomerulus. I don't know if you guys have ever heard of it. That sort of filters the bloodstream. And those are very small capillaries that are almost identical in size to the retinal capillaries. And so that's why diabetic nephropathy and diabetic retinopathy have almost equal incidence. So anytime it's that, so yeah, absolutely. There's some kind of metabolic byproduct that is preferentially destroying small caliber vessels all throughout the body. So that's why nephropathy, neuropathy, nerves are supplied by very small blood vessels. Retinopathy and coronary artery disease are the leading complications of diabetes. Yes?
So moving from OCT to OCTA and then measuring blood velocity and then hopefully measuring the blood flow, was this advancement in just the algorithms? Are we using the same set of data but further analyzing them, or do we need to have more insight to how light reflects on the exam?
So the machines that give you OCTA versus just OCT, they're being sold commercially separately, but really the proprietary difference is in the algorithm. There isn't anything substantially different about the equipment. And then in terms of this paper that came from MIT, what they were doing, that was also just an algorithm that they had created. So they're from basically the same equipment. They're mining additional information, which strikes me as brilliant. And so hopefully we can continue to do that. There may well be, to go beyond, for instance, say the 1 millimeter restriction we have in imaging depth, there may have to be a technological change. But so far, the major changes have all been in algorithms. It's pretty remarkable.
I think if you want to increase the depth, you have to increase the wavelength, and if you increase the wavelength, you lose the resolution. So it's
Really? That's sort of the trade-off?
Yeah.
I see, interesting. There may be other fields in medicine, though. I mean, there are plenty of other fields that don't need 5-micron resolution. So for them, that may be just fine. It's not good for the retina, where we love it, but certainly in others, that probably should be done.
Can I ask one more question?
Mm-hmm. Yeah, please.
Yeah. Where does the application of genomic medicine in ocular disease in general,
Yes.
retinopathies in particular, where does
Right.
it stand?
Right. So just separate from OCTs? Yeah, I'm very interested in that. So, well, there's a couple areas. So there are diseases that are Mendelian. So there's single genes that are mutated. And of course, you guys know about autosomal dominant versus autosomal recessive. In recessive diseases, there's typically some gene product that's not being produced. So if you could replace that gene product, the protein, you may well solve the problem. So most retinal degenerations are Mendelian, inherited retinal degenerations. So you may have heard of retinitis pigmentosa. It affects about, maybe not, it affects about 1 in 1,000 people. So it's certainly not common, 1 in 1,000 to 1 in 10,000, but you may have heard of it. And this can be really bad sometimes. In the most aggressive forms, it'll rob people of reading vision by age 10 or 15. It's pretty sad. Those are Mendelian, most of them. So for an RP-like disease, we now have, for the very first time, an FDA-approved gene therapy where what we're doing is we're using a viral vector, an adeno-associated virus that's been engineered to contain the gene product that's missing. In this particular form, it's an isomerase in the retinal pigment epithelium that's important for basically isomerizing the changed retinoid. The retinoid, the conformation changes when light hits it, and then we want to reproduce that so we can go through the light cycle again for the photoreceptors. So what they've done is in this AAV virus, they've engineered in the correct gene product, the isomerase. Then what we do is, and I'm happy to say I've been involved in a number of these surgeries back when I was at Penn, and hopefully we'll start doing them at Louisville at some point. We can do a retinal surgery where we remove the vitreous gel, which is standard for us. We go in, we create a localized retinal detachment, and we inject the virus, about 300 or 400 microliters solution that contains the engineered virus, underneath the retina. It transfects those retinal cells, and yeah, these patients have done, they're not reading, but all of a sudden they can do things like navigate in and out of a room and walk around a maze, which they never could do before. So the results for that trial have been really terrific. And there's only a couple other centers in the world that are doing it. But for inherited retinopathies, I think it's a tremendous treatment, and it's only going to evolve. Then for common diseases, in terms of genomic analysis, we've started to do things called genome-wide association studies, where we look for common single nucleotide polymorphisms, or SNPs. These are basically where we wouldn't really say that the gene's mutated, just a single base pair is different. And there are certain common SNPs that we're noticing that will contribute or increase the risk of, say, macular degeneration. The difference there is that these are multigenic, right? So, there are multiple genes that are increasing someone's predisposition to macular degeneration. And it's not like they're missing some gene product. That gene is still being transcribed into RNA. The RNA is then being turned into a protein. So they're still producing some gene product, and there's a whole bunch of different gene products that are implicated. So we don't have a good intervention for those ones yet. But they do tell us, hey, you're at higher risk. We want to see you more frequently, or you're at normal risk, and you're probably going to be just fine. So very big difference, of course, between multigenic versus single Mendelian diseases, but a very exciting field, and I think more to come in that area.
Thank you.
Well,
Please join me in thanking Dr.
Thanks, guys. Great to be here. And we don't mean to steal engineering students from engineering, but we love having engineers in medicine. So medical school is never a bad option.